Hello, everyone. Welcome to today's episode of the Rofi Collective podcast. My name is Larissa Assam. I am a child of God. I am a physician. I am a public speaker, a published author, and an entrepreneur. I'm also the CEO and founder of Rofi, and this is a platform helping women prevent complications in pregnancy and in postpartum. But today is actually not about me. I am joined by an incredible guest who I've actually known for a couple of years. Her story is powerful, and what she is doing is just incredible. This woman is a pioneer in so many different ways. Today, I'm joined by Dr. Christelle Samen. I'm actually going to turn it over to her to introduce herself because I feel like I will not do it enough justice if I was to try and introduce her. So please, over to you, Doc.
Hello, everyone. I'm Christelle. I am an anesthesiologist and interventional pain physician, and I practice in the state of Maryland. And yeah, I'm just happy to be here. Thank you for having me on your podcast.
You are most welcome. So, we want to really get to know who you are. We want to know you as Christelle, you as the anesthesiologist, as the pain specialist. What made you decide to become a doctor in the very first place?
So I always had an interest in science. When I was in middle school, I went to a fair and there was some sort of a science kind of experiment that they did. And at that point, I got really interested in science. And so I always thought that I would actually go into chemistry, and I had an interest in being a cosmetic chemist. And I actually wanted to make products, and I had kind of mapped it all out. I had looked up a bunch of different labs. I'd visited a lab in Delaware that made cosmetics. I had plans of, working for L'Oreal and doing all of these different things. And then at some point in my journey, when we were actually in a time of prayer and fasting with my church, my freshman year of college, that's kind of just something that I brought, before God to really ask him, what is it that you want me to do? With my life. And through that season, he made it clear to me that, he was calling me to medicine. And so that's really kind of where that journey began for me.
Wow, that's amazing. And cosmetic chemistry is not something I hear people talk about very
So
often.
it was very hard to even. Now I've seen a lot more, especially on Instagram. I see quite a few cosmetic chemists on there. At the time, I mean, Google and everything, it was really hard to even come across people. So it was actually pretty cool that I was able to find a lab in Delaware to do that.
Yeah, absolutely. Wow, very interesting. You did something important. You brought this before the Lord in prayer and fasting, and that's just so incredible. I remember, I mean, I wasn't walking seriously with God when I first started on my trajectory to medicine, even though I proclaimed to be a Christian. I didn't really pray often or fast at all, actually. But later in my journey, when I was kind of transitioning between specialty choices, then I applied, that principle of praying and fasting and bringing matters before God. For you, how has that helped you through life? Just a lifestyle of prayer and fasting.
It's been really central, honestly, to really everything that I do. And even, just kind of the concept of getting through medical training, right? It's a very stressful process. It kind of demands a lot from us. It's definitely a process that can really strip you in a lot of ways, right? But just really kind of really take a lot out of you, to get through it. And so that is definitely something that helped me stay grounded, helped me reset, helped me to really kind of stay encouraged and stay hopeful even when the journey got difficult. So very big part of my life for sure.
That's really good. So to anyone, who's starting out, it's actually match week. It's 2026 now and it's match week and people are getting ready to start residency. I think that's something you should keep in your back pocket to know that, especially when times get hard. But I think you should make a lifestyle out of it. So it's not just waiting for the bad days, so to speak. Prayer and fasting, they go a long way. And now that I have applied those principles to my life, I see the fruit. So you decided you wanted to be a doctor. And
Mhm.
so you were in college at this time. Was it smooth sailing for you? Was it immediately from undergrad? Did you take a gap in between? What did that look like between undergrad and then I guess starting medical school?
Yeah, so I did matriculate. I was very grateful to be part of a very supportive program in undergrad called the Meyerhoff Scholars Program.
Yeah.
A lot of resources, a lot of support for us. And so, by God's grace, I was able to matriculate directly from college to med school. But I know things have definitely changed since then. I think that's much less common now. People kind of prefer to do a little bit of time off between the two. So I think I kind of just come from a generation where we just kind of went through if we could. So things are definitely different these days for people, and a lot of people explore other things before going to med school. So I think that's cool too.
Yeah, that's huge. And it's now that you say it, now in retrospect, it's true. I also went directly from undergrad to med
Yeah.
school, and I was quite intense about it too, But as you said, things have changed. Even back then, a few friends, were kind of contemplating gap years and things. But I knew myself. I knew that I know my personality. If I took a gap year, it would have been over. So I
Mm,
was the kind of person who actually kind of needed to go directly. But that's also good to hear and encouraging because sometimes people automatically think that they have to take time off, but that's
right.
not the case.
Yeah.
So I think it's good to hear the different perspectives. So thank you for sharing that.
Yeah.
So you go on to medical school. Did you stay in Maryland? Did you leave the state? Tell us a little bit about that.
Yeah, so I left the state. I was in St. Louis for med school, so that was definitely a change. I'd never been to the Midwest before. So the culture was different. Learned a lot about just kind of a different way of living. So it was really cool. I got exposed to a kind of a different aspect, I think, of the way that medicine's delivered and patient populations. The med school that I went to is Washington University and St. Louis School of Medicine, so it's in the city. So it's a really good mix, where we have an indigenous population, and then we also have a rural population that seeks care there, because it's kind of the tertiary care center for a lot of different states. And so we have people coming there to get specialized care. So it was really a wonderful setting and environment to really learn a lot and get exposed to a lot.
Okay, amazing. Now, had you ever been to the state before starting medical school?
No, I had never been there before. Other than my interview. Yeah, I had been there for my interviews. But no, I'd never been to Missouri before.
Okay, okay.
Yeah.
So you start medical school, you're going through the journey, and then, there comes a time when every medical student has to make this decision about what specialty they want to do. And so you decided on anesthesiology. Why?
That's a great question. So, I thought going into kind of medical school that I would do, emergency medicine because I knew that global health and being involved internationally is something that meant a lot to me and was important. But I did my emergency medicine rotation and I just didn't really love it. And I think it's important to love what you do, right? And so I really kind of was sensitive to that and open to the fact that I would enjoy what it is that I end up doing. And so I went through, my third year, and it was actually really a blessing because our surgery clerkship was 3 months. And at the time, one of the options was actually an anesthesiology rotation. And at the time, it was a 4 week long rotation. And we were able to rotate through all the different subspecialties of anesthesia. So I really got exposure to everything, from pediatrics to obstetrics to interventional pain to regional anesthesia, to neuro anesthesia, cardiac anesthesia. So it was a great rotation to even preoperative, optimization clinics. And so I was really able to see the breadth of what it means to be an anesthesiologist. And once I was done with my entire third year, that was really the rotation that stuck with me. I knew that I liked procedural specialties and I liked using my hands, and I had done a lot of work previously that required the use of my hands, and I had a level of dexterity, and it's just something that I knew that I enjoyed. And so at that point, I made the decision that I was going to pursue anesthesia. And what I really enjoyed on my anesthesia rotation, in addition to kind of just OR-based anesthesiology, was actually the pain exposure that I got. And so exposure to the acute pain side of things, and the acute pain service, the regional pain, which is when we do nerve blocks and place different epidurals in patients before surgery. And then also the chronic pain side, which, involves clinic and involves other procedures as well, and allows us to kind of have a longitudinal relationship with patients. And so I really, really, really fell in love with that. And that's really kind of how I made that decision. Yeah.
Wow, that's huge because when I was in medical school, I rotated through anesthesiology and it was exactly 1 week long.
Yeah.
The fact that you had that 4 week
Yeah.
long experience, I think it's amazing how God knows how to place us exactly where we need to be to get whatever exposure we need. And so, you started to touch on it, but there's so many different things that anesthesiologists do.
Yeah.
There's obstetrics, there's cardiac
Yeah.
anesthesiology, the outpatient portion of it, the perioperative optimization, as you mentioned, and then pain, which is so needed in today's day and age because in the primary care setting, I can tell you, you reach a point where with some patients that's happened to me when you're like, I need to refer you out because we're a bit limited on options.
Right.
So I have a sense of some of your outcomes that you've even shared with me about some patients, how you've been able to help them. So maybe tell us what are maybe one or two of your favorite stories
Yeah.
being able to impact the life of a patient as you've helped them manage their pain, whether it was acutely or chronically.
Yeah, some of my favorite experiences have been having patients that were grandparents and were really limited in being able to literally just carry their grandchildren, play on the floor with their grandchildren. Some of my patients had never really held their grandchildren in years because of pain, and they were concerned of hurting them or dropping them. And being able to help them through that, and with different procedures and being able to get them to the point where they're able to hold their grandchildren for the first time or for the first time in years, that meant a lot to me. And sometimes I get tearful in the office visits when patients share some of those outcomes. So those were some of the really most special moments. And even when it comes to, the acute pain side, there are several experiences that I've had, even with patients maybe who with whom there was a language barrier, so that was something I remember very distinctively at different intersections, whether it was I had some Spanish speaking patients or I had some French speaking patients, and I was able to connect with them in a time really of distress because whether it was kind of before labor and delivery or, things like that, just kind of talking them through different processes. And they were really comforted by the fact that I was able to speak to them in their language, which obviously, I would get the translator on board for the consent and things like that. But being able to just kind of get in the room and speak to someone in their native tongue was something that they expressed meant a lot to them. So that's been really special too.
Oh, I love that. That's powerful. And it's something that you may not always think about, but wow, grandparents not being able to play with their grandchildren.
Yep.
That's huge. And also, a word stood out to me as you were speaking, distress.
Mhm.
As you were speaking, I thought about it. I was like, wait a minute. If I was to take a step back and think about it, majority of your patients are actually in some degree of distress. Acute distress or chronic distress is another way in which we can actually
Right.
describe what you're managing
For
each
sure.
time with your patients. Wow.
Absolutely. Yep.
Wow. How do you fill your cup up so that you're able to help other people manage their distress, so to speak?
Just like we talked about, that's why really prayer, worship is something that I really is a really big part of my life. So worship music, that's one of the ways that I reset. And then there was also a practice that I adopted in medical school. My pastor is Stephen Chandler of Union Church in Maryland. I remember we were just kind of talking through some of the stresses I was going through, and he asked me, is there a day that you take off during the week? And I'm like, what do you mean? Like, what do how am I gonna not study for a day? And he's like, yeah, it's a practice, and it's kind of, observing set, not necessarily in a, legalistic way, right? But it's the concept of us really giving one day and kind of honoring God with that and trusting him with the six and trusting him with the work that we did with the six and trusting that as he's kind of invited us to rest on a seventh day, that he's going to bless what we did in the 6 days. And that's really a practice I started to adopt in medical school that has continued, so even as I was studying for the board, step one, step two, step three, anesthesia boards, written board, basic exam for anesthesia, which is the first board exam, written boards, oral boards, I continued to adopt that practice. And earlier on, I remember, I tried to make it Sunday, so it could be like, I'd go to church and stuff, but I would find that on Saturday, I just was burnt out from the week. So Saturdays became my rest day. And then Sundays, I would go to like the first service, and then I would kind of study the rest of the day and things like that. So, yeah.
Wow, powerful. Another very practical lifestyle habit to implement. The nature of work that I do, because of the capacity in which I now serve at church, it used to be Sundays for a season, it
Yeah.
was.
Yeah.
But then I started to realize, okay, I can't rely on Sundays because I need to show up on Sundays as well.
Right.
So for me, Thursdays have now become my day where I kind of spend time in prayer, study, reading the scriptures, listening to sermons. But to hear that this is an ongoing practice in your life is very exciting, because I wish more people, especially physicians, would do this. The burnout rates are really
Yeah.
high.
Yeah.
And I think these practical lifestyle habits are necessary. That's powerful. And you've done that since medical school days.
Yeah.
Okay, so we were journeying along and we were in medical school. You had decided on anesthesiology. You were at this time in Missouri. So, what made you? So now you're clear, it's anesthesiology you want to do. Um, what was that like? Matching into anesthesiology. Did you know you wanted? I mean, I know where you trained, but I want you to actually mention it because I think it could inspire someone. Um, did you know you wanted to come back to the DMV? Tell us, please.
Yeah. So I definitely knew I wanted to come home. And so yeah, so I, pursued different opportunities in Maryland and, DC and Virginia. And my top choice was Hopkins, and I matched there by God's grace. And it was just such an incredible day moment. And it was really just, the goodness of God, because I had gone through several challenges. And so that was really a moment and a reminder that, God can really be trusted with our journey. And yeah, so I was really excited to come back home for the rest of my training.
Amazing, amazing. It just occurred to me. I'm like, I think we discussed this before, but it's amazing. We're both Hopkins alum. I
Yeah.
love I love that. So you're at Hopkins, you start residency, intern year, and then going. So you started to say this before, but just tell us in a nutshell what anesthesiology training is like. Maybe some people have never known that anesthesiologists even go
I
through
know.
residency. How
Yeah.
many board exams do you have to take? Oh,
Yeah. So, anesthesia training it can vary. So there's something called like categorical programs, and there's something called advanced programs. So categorical programs are essentially where you go in, and the 4 years are kind of 4 years of programming for anesthesiology training. And an advanced program is when you do your first year in an intern year or a transitional year. And then you do, PGY 2, 3, and 4 within the anesthesia program. So Hopkins at the time was solely advanced. And so I did my intern year at Mercy Hospital in the city in Baltimore. And then I did my PGY 2, 3, and 4 at Hopkins for the rest of my residency. And we rotate through the ICUs. We rotate through goodness, we do pediatric anesthesia, we do obstetric anesthesia, we do um heart bypass surgery, we do lung replacements, we do clinic, so we do optimizing people before surgery. We do rotations where we're in the recovery units helping patients recover. We're monitoring for complications that occur postoperatively. We do regional anesthesia, so that's a rotation where we're doing nerve blocks, right? Where we're able to get patients through surgery sometimes literally with just an injection of local anesthetic, and they're able to get, different amputations or different orthopedic surgeries. We do interventional pain, right? So that's kind of what I ended up specializing in when we're in a clinic setting and we see patients and we kind of help them through that. So it's a very, 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 very storied and very broad training, which was actually one of the things that attracted me to it. I really wanted to have an understanding of pathophysiology from children to, the elderly, men and women. And so that's literally what we do, and I mean, our boards, we have basic exam, which we have to pass before matriculating. Technically, we take it at the end of our PGY 2 year. And then we have the advanced exam, which is our written boards. So we sit for that at the end of residency, and then we take our oral boards. So it's pretty intense.
Oh, yes, it is. And in medicine, we have, I guess you can call it an internal joke. There are some specialties that people say are they're relaxed and they're chill, and people say anesthesiology is one of them. But
Mhm.
as you've just listened to the grueling training she's gone through, there's nothing chilling about this training. I think that many people who especially are going into surgery, because in the operating room, you're on opposite ends of the table, so to speak, they
Sure.
see that the anesthesiologist is sitting down and either reading a book, usually reading a book, they're relaxed.
That's certainly the stereotype.
Yes, sir.
That's certainly the stereotype.
But I think it takes someone who is confident in their craft to be able to be calm under pressure. And I think that the nature of your training prepares you for that. And so, to everyone who's listening, don't underestimate anesthesiology, and why not sign up for a great specialty that's going to give you well rounded medical knowledge, confident in all kinds of settings, and still be so versatile in what you can do.
Mhm.
So, now you choose anesthesiology, you train at Hopkins, and then you decide on pain.
Yes.
So tell us about that transition now from anesthesiology as you'd known it into pain, which you knew was the direction you wanted to go regardless.
Yeah, so that transition, I had done some rotations within the pain clinic at Hopkins, so I was familiar with, kind of what to expect as far as the different attendings I was going to be working with and, the flow of the clinic and things like that. So that was really helpful. But it's a whole different set. Thankfully we're very procedural, right, as anesthesiologists. So there was that foundational knowledge and background as far as procedural expertise. We were placing epidurals for years. And so, but it was placing epidurals differently, right, under image guidance. So it's a different position that the patient's in. It's a different technique. You're learning how to do image guided procedures. So watching your x-ray, which again, there's that foundation of having done image guided procedures with ultrasound as an anesthesiologist. But now it's fluoroscopy, and you have to learn fluoroscopic anatomy. And so it's a whole other set of knowledge base. And again, because of the anesthesiology background, pharmacology was something that, was pretty facile and things of that nature. But it's really an entire new set of procedures that you're learning. And then, Hopkins was a multidisciplinary fellowship. So we rotated in psychiatry, we rotated with physiatrists and the sports medicine clinics. We did some time kind of in different settings. And so that really allowed us to get a very well-rounded experience, right? Where we were able to see a lot of different things and have exposure to a lot of different aspects that affect patients in pain, right? Like psychiatry and, sports medicine and movement and all of those things. Yeah. Neurology as well, we rotated with.
Wow, this is amazing. And I love that you're sharing the journey because sometimes people can meet a doctor and not really know the breadth and the depth of the training and the life experiences too. Because we're talking about formal clinical training,
Yeah,
but I always say to people, there's still life happening. There's
absolutely.
life happening every single time as you're going through the journey.
Yeah.
So this is incredible. I love that. I wouldn't think of, that multidisciplinary approach, psychiatry, certainly sports, I would think, but that's awesome that that was weaved in. So, as you know, I take care of a lot of pregnant patients.
Yeah.
I take care of a lot of postpartum patients. And one of the things I find right now in today's day and age is I seem to have a very unique patient population, so to speak. People who uh, they don't like medication too much, they don't like too much medical intervention. We know that epidurals for a long time have been used to help with pain management for women who are pregnant.
Mhm.
So, what are some myths perhaps that you may know about epidurals
Yeah.
that could be helpful for us to know about and maybe dispel today?
Sure. Yeah. So, I think a really big myth about epidurals is that epidurals cause back pain. And so I think that, and that's something that I definitely discuss with patients when I'm consulting them on labor and delivery. And, a lot of times there's kind of that association that's made, but that's not necessarily always a correct association. So that's something that I like to kind of counsel patients about, gaining a little bit of a better understanding with. The second thing about epidurals that I think sometimes a misunderstanding about is really kind of understanding how the medication flows through what we call the epidural space, right? And so um, it, it involves gravity. And so that means that if you're in a certain position, the medication is going to kind of flow right in that direction. So really having understanding that the position that you're in is going to affect the way that some of your nerves are kind of seeing that medication, and some of the sensations that you're experiencing, I think, is another important thing. The third thing, kind of myth, that patients may have is the fact that there's a misconception as well that with an epidural, you kind of employ the services of a doula, which that's not necessarily the case, right? And so there is still some movement that you can do. You can still certainly use a peanut and do certain movements to really help progress labor. Um, and not necessarily just kind of be laying down in bed the whole time after the epidural. So I think kind of empowering patients to understand that is something that's very helpful.
Okay, that's great. So positioning matters. Understanding that back pain, although it could happen, it doesn't necessarily mean it's always due to an epidural that was inserted.
Right. Because pregnancy on its own and the changes that happen in the pelvis with pregnancy, as well as the changes that happen to the core, right, which is going to put essentially the discs at risk, and susceptible. Those things are all risk factors for the development of back pain,
Mhm.
right? And so just kind of understanding that it's not an independent thing.
And that's a big one that, having an epidural doesn't necessarily mean you can't move at all, so to speak.
Mhm.
You can still use a peanut or other things. Okay, very helpful. Any other advice that you would give to women, generally speaking, as an interventional pain medicine physician?
Yeah. So the advice that I'd like to give to women and that I actually give to all my patients is it's very important to trust your care team. So if you feel that you cannot trust the person that you're seeking help from, or you feel that you don't have a good, what we refer to as a therapeutic relationship, like you don't necessarily feel heard, you don't feel listened to, you don't feel like your concerns are being addressed appropriately, I think it's very important to seek the care of someone that you feel like you can have that therapeutic relationship with, because trust is so important, and that's kind of something that I really counsel patients on. I'm like, ultimately I want you to be well. So whether that's with me or whether that's with someone else that you have a better fit with, is really making sure that you trust who you're pursuing care with. So that's a really big thing for me.
That's amazing advice. And I think that applies across the board, every specialty. 1000% agree, because that alone is enough to invite fear or discomfort, and it just messes up the whole situation when it's probably already a distressing time if they're even considering you as a physician.
Exactly.
Yeah.
Exactly.
So that's great. Thank you so much. This has been rich. I think it's been very impactful, concise, and impactful. But let's say someone wants to connect with you further. They want to learn more about pain medicine. Please
Yeah.
tell us how we can connect with you.
So I'm on all platforms as the pain relief doc. So there are going to be a lot of resources there, a lot of educational content there, explaining a lot of different kind of, issues with pain, reasons for pain, understanding what's going on in your body. And then I also share some nutritional tips, some lifestyle tips, things that you can incorporate, lifestyle modifications, to feel better, to move better. So that's what we're doing there, and some exciting things in the pipeline. So definitely stay connected.
Amazing. Thank you so much, Dr. Salmon, for your time today. God bless you. God bless you. God bless
Larissa.
you.
Thank you so much.
All right.